Hello friends, I am Dr. Mahesh Mohite, a pediatrician and pediatric intensivist from Panvel, Maharashtra. I am recording here a next talk in our steer series which will be clinical assessment of respiratory function. Is it possible? So friends, when we talk about respiratory system function, it's nothing but getting oxygen from the air to our tissues and getting CO2 out of your lungs into the atmosphere. The first one being called as type 1 function, and failure of that is called as type 1 respiratory failure. The second one, that is CO2 expulsion, is type 2 respiratory failure if it is hampered. Both are derived from alveolar gas exchange, but dropping blood oxygenation is surrogate of failing gas exchange across alveolar membrane, which is type 1 respiratory failure, while rising blood CO2 is kind of a surrogate of ventilatory mechanism, that is type 2 failure. So hypoxia is type 1 and hypercarbia is type 2 respiratory failure or respiratory dysfunction. Rising CO2 in blood cannot be detected clinically except few indirect non-specific markers, like in a suspected case or kind of a pre-setting of hypercarbia. If the child start getting tachycardia or sweating, then you may suspect, but there is no definite marker of it. Vis-a-vis, dropping oxygenation can be clinically detected, but unfortunately you will have a cyanosis appearing when the saturation go below 75 or 80%, while in a clinical scenario anything below 94% is to be taken as hypoxia. There is a huge gap between what you clinically can detect and what actually is hypoxia, and that's why pulse oximetry is considered as a fifth vital parameter which need to be detected, which need to be used to have a array identification of hypoxia in a given patient. The clinical manifestations of hypoxia can vary from whether it is acute hypoxia or a chronic hypoxia, and depending upon associated history and clinical features, a probable sign of origin of pathology can be determined, whether it is coming from alveoli, it is coming from interstitium, whether it is coming from airway. You can have a reasonably good kind of a localization of the pathology in a given patient. So how do you go clinically in an acute respiratory dysfunction? Obviously, first thing to do in such patient when he's sick is to first stabilize him to the optimum level before going into detailed evaluation. Once you stabilize, good detailed history, the onset, duration and progress is important. From the onset point of view, you have to determine whether it is inflammatory or infective, which is most common as far as hypoxia is concerned, wherein it could be just cough, high grade fever followed by cough followed by breathlessness, telling you probably it's a classical pneumonia. Vis-a-vis, it may be a wheeze, which may be an early marker of it, which may tell you it could be asthma, or acute large airway obstruction, choking, as in cases of an infant coming with choking due to foreign body, aspiration. So those history need to be taken. You also may be going into associated features of associated cough, dyspnea, chest pain, maybe subsequently he may be having a prolonged seizure giving rise to type 2 respiratory failure. He may be on some medication or a kind of accidental consumption of medication or some drug abuse, which may land up in type 2 respiratory failure, sometimes even in type 1 respiratory failure. The duration of disease determines what to expect as far as manifestations of respiratory dysfunction is concerned, and I'm going to tell you about the chronic respiratory dysfunction manifestation in the subsequent slides or subsequent kind of my presentation. Progression is very important. Specifically, you have a child, kind of a bigger child who was walking, who stopped walking, then stopped standing, then stopped sitting, and then cannot even roll over in the bed, which may be a progressive weakness in acute short duration, as in cases of Guillain-Barré syndrome. And this child started becoming shallow tachycardic or shallow tachypneic with a tachycardia, with a sweating. This may be a marker, and then you notice saturation is going down, even slight, which is sort of a late presentation, and he's heading for a type 2 respiratory failure because of respiratory muscle weakness. You also need to take a past history, like you have a history of recurrent wheeze and the child comes with tachypnea and hypoxia. This could be a asthma which is graded into stage 2 or stage 3 of asthma. A relevant other history is very important. A family history of allergy or asthma, family or history of traveling may help you in few of these patients in evaluating hypoxia or hypercarbia. So the onset, duration, progress, clinical history is very important. As far as clinical examination is concerned, you may be seeing the markers of compensatory respiratory efforts when there is a kind of a respiratory challenge, and which may come in the form of tachycardia or tachypnea or associated respiratory distress. When I say that, you are having accessory muscles of respiration being used to maintain the vital parameters, which will come with maybe suprasternal retraction, alenesia, flaring, intercostal, subcostal retractions, or could be sternal retractions. So all those things along with tachypnea is a marker of respiratory challenge. There will be abnormal mechanics suggesting you probable origin of a kind of a pathology. So you may have a stridor representing upper airway obstruction. You may have wheeze representing small airway obstruction, or grunt telling you that the alveoli are under kind of a strain. So in case of stridor and wheeze, you may be expecting hypercarbia. In case of grunt, you may be expecting early hypoxia. The clinical respiratory examination further, as far as various zones are concerned, you may be coming to know whether it's alveolar pathology, pleural pathology, or somewhere else. Clinical respiratory examination is so very important. A detailed examination can be discussed in any of the other sessions. Also important to note the hemodynamic assessment to determine effects of respiratory function or abnormality. So when the respiration is under kind of a compromise, you will have effects of it on the heart. In fact, the first marker of any respiratory challenge will be tachycardia, which definitely need to be noticed. Also, in extremes of the situation, you have shock suggestive of a severe respiratory challenge and which need to be addressed, which is rather a hemodynamic compromise secondary to respiratory failure. We also need to understand the red flags in a given scenario. So, if you are anticipating hypoxia in such kind of a patient, which is type 1 failure or hypercarbia, in the later part, the child may become lethargic, drowsy, or decrease activity due to hypoxia. So, child of such kind of a preset history, which may lead to respiratory failure and comes with lethargy, drowsiness, that's a red flag sign and requires immediate resuscitation in the emergency room or in the ICU. The child with coming with in this kind of history or respiratory infection or alveolar disorder, probably underlying. If it comes with grunt, that is suggestive of losing alveolar volume, losing lung volume, or losing functional residual capacity, and grunt being a body's compensatory mechanism of a protective response to maintain the alveolar volume. So grunt is a sort of a very critical sign where this child requires immediate resuscitation to keep the alveoli open by giving a positive pressure and expiratory positive pressure device, the PEEP device. In a given child who is having progressive kind of a weakness from maybe lower to upper part of the body, and then subsequently getting saturation, you are monitoring this child on a pulse oximeter, and the saturation even drops from 98 to 94%. Now this 94% in any other child, you may consider it's okay, or if this comes to maybe 90%, somebody may give oxygenation, but this child is failing because of the type 2 respiratory failure, that is neurological failure, and this oxygenation drop is in fact coming after the CO2 has already accumulated in the CO2. And this child, if you give oxygen, then he may crash because he is surviving on hypoxic and hypercarbic kind of a stimulus, and if you give oxygen, then he may crash because that stimulus or drive to the neurological system is lost. So here the ideal treatment will to take care of the airway and intubate and ventilate this patient. So this is type 2 respiratory failure in the GBS, which need to be recorded as kind of again a dreadful sign. So these red flag signs need to be kept in mind. When we come over to chronic respiratory dysfunction, their manifestation will be slightly different from what I discussed in the acute part, and there body tries to compensate for that chronic dysfunction or chronic hypoxia and hypercarbia by reducing the demands and that will manifest as poor activity and fatigue in this child. So chronic hypoxia rather will come as fatigue in this child. On any exertional activity, this child may quickly become dyspneic. So it could be dyspnea on exertion, which may be manifestation. There will be body's efforts to improve the oxygenation by increasing the microvascularity in the body, which clinical guideline can be seen as clubbing in this chronic hypoxic child. Or again, the child may be compensating by increasing his hemoglobin levels so as to carry or increase oxygen carrying capacity. This typically will be seen in the patient kind of a people staying in the high altitude area where they are a bit polycythemic to maintain their oxygen carrying capacity and to maintain the oxygen supply to the body. So this child may have clubbing, this child may have polycythemia coming up in this. Not to forget all these compensatory mechanism or decreased activity and decreased kind of a body metabolism will lead to significant growth failure. Depending upon the duration of it, it may be acute growth failure or chronic growth failure. More blood supply inside of the child will push a lot of blood into the lungs to have maximum oxygen gain from it, which may over the time may lead to pulmonary hypertension, which may happen either in cases of hypoxia or hypercarbia. So these all are kind of a clinical manifestations of chronic hypoxia, which is fatigue, clubbing, low grade cyanosis, or maybe they may come up with polycythemia, or ultimately, if not detected and managed early, may lead to pulmonary hypertension. So friends, to summarize about respiratory clinical examination, clinically recognition of respiratory function and dysfunction is possible if you have a knowledge of respiratory physiology well. The history of background disease plays a major role in such diagnosis, and type 2 respiratory failure marked by hypercarbia is difficult to recognize clinically. So there you may have to look at the indirect kind of a surrogates of this thing. But type 1 respiratory failure marked by hypoxia, either acute or chronic, can be recognized by detailed clinical examination. Localization of the cause of hypoxia is also possible clinically. Thank you very much. We'll be meeting you in the next session. Thank you very much.